So we want to think about what we see. So these are some of the things that you might recognize as you're coming across them in the clinic. Any type of urinary dysfunction, frequency, urgency, urge incontinence, stress incontinence, those are all things that we can help with. It can be physical therapy that is supplemental to surgeries that are indicated. It could be PT as an alternative, or to see if that's going to work ahead of time. Same thing for medications. We treat defecatory dysfunction, and you name it, pain-related, and we see it. So the pain could be of a neurological or a musculoskeletal origin. It could go by names that you probably have heard some here out of urogynecology, a short tight pelvic floor, talking about myofascial pelvic pain. Also some of the named pain syndromes, such as interstitial cystitis and vulvodynia. Again, anything that connotates pain. If it's pain from the belly button to the hips, it's something that we can see, especially if you have ruled out that there is anything more sinister going on. That's absolutely something that we can see. So with regard to who's talking about it, and to find out what they're saying, I left off a review of the literature because there's a lot going on there, but we want to really know what's being said in mainstream media, because this is what your patients are hearing. We know that there are a lot of providers that still don't know about pelvic floor PT, but increasingly the women you will encounter in your work are hearing about it from mainstream sources. And this is actually a clip that's about 2.5 years old, a little older, where Dr. Northrup appears on Oprah. She's fielding a whole battery of questions. She gets one comment that says, "Laughing makes me run to the bathroom," and then it says, "Help, and what do I do here?" And so she essentially is recommending Kegel exercises. She says that these can be very, very helpful in strengthening your muscles of the pelvic floor. It can help to elevate the bladder and help to prevent any of those accidental leakages. She also then goes on to say that if you don't think that they work, it's important to go to a physical therapist to make sure that you're doing them correctly. And there actually is really solid research that backs up that statement. A study in the 90s that showed that 50% of women who were given a really clear and concise verbal instruction in how to do their Kegels were not able to do them properly. So that there can be a real motor control disconnect between their ability to think that they understand. I mean, and they may truly understand what you're saying and what you're instructing, what you're asking of them, but their ability to actually execute the proper activity is pretty impaired. And if that's half of the people that are just getting a recommendation, a verbal recommendation to do Kegels, it's a pretty significant proportion of people. And we've certainly seen it happen in the clinic where what they are trying to do is the complete opposite of what we're after. I mean, it's actually a Valsalva. And goodness knows if we've made a recommendation for them to do 50 Kegels a day, we sure don't want them doing a Valsalva 50 times a day, trying to do the right thing. We're going to be in a lot more trouble down the line. So that's where just making sure that that gets checked and that everybody for whom it's recommended is doing it properly is very important. So then, the beginning part of this year, Dr. Oz actually had a whole show on vulvodynia. And I learned of this actually through a patient who thinks that Dr. Oz just makes the world go round. I mean, if he recommended put dirt in your oatmeal and it will make you healthier, she would do it. And there are a lot of people in her boat, a lot of people that are listening to what he's saying. And so among his many recommendations for what to do for vulvodynia, he says to seek out practitioner-based therapies. He recommends that patients who see a physical therapist, that patients go see a PT who's experienced in treating women with vulvodynia. And, you know, goes on and provides a pretty good general statement that just says we're going to look at muscle tone, contraction strength, structure of the pelvic floor, and look at this as a potential trigger for pain. It may not always be the answer, but any PT that you send to should be trying to figure out, does this belong to me? You know, is this a patient that I can help? What do I see? What do I find? And are these things that I can help change? And if not, we will be the first to give them right back. But there are a lot of things that we can look at in addition to what you look at. And then very recently, just last week, this story appeared on the Common Health blog on our local NPR affiliate. So the quote that you see there and can read is from the article. Says that there's this insidious onset of pain during sex. Fortunately, within a pretty timely manner, consulted with a OB, Dr. Hardiman in Cambridge, who recommended physical therapy and said, you know, Dr. Hardiman's words were, you need pelvic floor massage, and you can see in the parentheses that you can imagine what I envisioned, and I can imagine what anyone would envision when that's being recommended. So as the provider that you're trying to convince someone to go see, I would ask you respectfully not to use massage, because it does conjure up some images. But to just talk to them about how, you know, in the same way that they could recognize that muscles in their back could be a source of pain, or muscles in their neck could be a source of pain, that's what it is. And the same techniques that they would imagine that help to release those muscles are what we're going to do. I mean, there certainly are transvaginal and transrectal techniques that we use. If someone is absolutely averse to it, we will even see what we can do to work around that. So just given a recommendation for pelvic floor PT, as you can see in the article, or as you will see in the article if you can look it up, is that she goes on to say what her experiences were on the first time that she went. That actually was very good. She was put at ease with the PT, given some explanations on anatomy, made it all fit a little bit better, and really started to have a sense of both promise and trust in the process that would unfold with PT, and some preliminary good outcomes on the first visit. And what's really interesting that I have on the following slides is how well this has been received by the public that has been following it. There's a series of comments that have all been posted, and I would really encourage you to go check those out, and I brought a few of them here. So one is by a woman in her early 50s who says that she's had pain with intercourse her entire life. And, you know, she indicates, I mean, in a few sentences, really is able to indicate how much this has affected her mental health, how she has had to come to terms with this really on her own, and has felt either not supported, or at least that the medical community couldn't help her get any answers. You know, she says that she would ask the doctors about it and gave up because she didn't have anything they could see. And that's where, you know, we're often looking at the things, we as PTs are looking at the things that don't show up. They're not going to show up on a diagnostic test. They're not going to show up on labs. They're not going to show up on pelvic exam, but that's when we kind of get into the next level of what are the potential causes for the pain. So this would be somebody, certainly, I mean, if when she first, 25 years ago, said, you know, I have pain when I insert tampons, even if she wasn't sexually active at the time, that alone maybe should start being a red flag to any of us that encounter people like that, that is not something that should hurt. So here are a few, and I really like all of these. The first is just a big thank you for the article. She's a midwife and an RN, and she didn't know anything about pelvic floor PT, and is really excited to learn more about it. So they're going to be following blog entries, and again, I would really encourage you to take a look at those probably sometime in the next week, maybe 2 weeks at the longest. You'll see some follow-up to that. And then in the second, a childbirth educator and a doula who, again, has never heard of pelvic floor PT. She's also a mom of 2 who really could have benefited after her first baby. She said she had terrible pain. She had a pop stitch after she'd torn giving birth, and walking was terribly painful. Sex was painful for well over 1.5 years. And, you know, I'm a mom of 2 and almost 3 at this point, and that's just not acceptable. And I think too many women think that it is just the badge of parenthood. That, well, you know, I had my baby's healthy, and it could have been much worse, and, you know, you expect that things will change. And people who have told me that that's the medical advice that they've been given too. Said, well, it could have been much worse. Well, your baby's healthy, and your body's not going to be the same after.